Hello, and thank you for joining us. My name is Rachel, and I'm the president of the Pericarditis Alliance, and I'm also a pericarditis patient. On behalf of the Pericarditis Alliance, we are pleased to bring you this special program. The Pericarditis Alliance is a nonprofit organization dedicated to the proper diagnosis, management, and treatment of pericardial disease. During this hour, you will learn about pericarditis from Dr. Alan Lewis from the Mayo Clinic. And then next, Dr. Alan Klein from the Cleveland Clinic will provide a brief introduction to the new Journal of American College of Cardiology, or JACC, Concise Clinical Guidance Document. And Dr. Massimo Amazio from University Hospital, Santa Maria della Misericordia, will provide a brief introduction to the new 2025 European Society of Cardiology, or ESC, guidelines. And then for the remainder of the hour, you will have your pericarditis questions answered by the aforementioned Dr. Alan Klein, Dr. Alan Lewis, Dr. Massimo Amazio, along with Dr. Martin Lewinter from the University of Vermont Medical Center. A fellow pericarditis patient, Andy Crossley, is joining me from the UK to co-moderate questions. So thank you to everyone for submitting questions in advance. Due to the large number of questions that we received, we summarized them so that we could include as many as possible. And we cannot answer questions submitted in a chat. At the end of the program, we will show the names of our presenters and their locations, as well as our website and contact information. On our website, you'll find biographies of all of the doctors presenting this hour, and they're also our board members. You'll also find helpful links to articles and information about pericarditis. And we also have links to 4 of the Centers of Excellence for Pericarditis: the Cleveland Clinic, Mayo Clinic, Columbia New York Presbyterian, and Northwest Medicine. Lastly, this will be recorded and we will post it on our website soon. So to begin, I am pleased to introduce Dr. Lewis to share with us what is pericarditis.
Thank you very much, Rachel. And I'm just going to share my slides here. And so I'm going to start off with an introduction of what is pericarditis. And as a number of you know, the heart is surrounded by a bag, and that bag is called the pericardium. Between the pericardium and the heart lies a thin layer of lubricating fluid called the pericardial fluid. As we all know, there are a variety of different definitions and guidelines of what is pericarditis and what are the different kinds of pericarditis. We generally think of acute pericarditis, which is a single first episode of pericarditis, and then incessant, recurrent, chronic, and constrictive pericarditis. The difference between incessant, recurrent, and chronic are largely for clinical trials, and really these are pericarditis that either hasn't gone away or pericarditis that keeps coming back. So what's important in the assessment of pericarditis? It's really important that we as doctors hear your story. What was it that you were actually feeling? And we really need to know how long it's going on for, what's going on, what medications you've had before, and how these medications have been tapered off before, because this really helps us guide future treatment. It's important to recognize that even though we have episodes of pericarditis, sometimes we can be more sensitized to feelings in our chest that are not related to pericarditis. And it's important as physicians that we are able to distinguish what is an episode of pericarditis that responds to treatment and what are other causes of chest pain that require other therapies to make you feel better in addition to your pericarditis treatment. We examine people looking not just for signs of pericarditis, but also alternative causes of chest discomfort. I think the most useful lab tests in pericarditis are those of inflammatory markers. These are the CRP most commonly, as well as the sedimentation rate. And this tells us if there's inflammation going on anywhere in the body, literally from the top of your head to the bottom of your feet. It's not pericarditis specific, but it tells us that there is inflammation going on somewhere. And then in terms of heart imaging, the useful imaging tests that we use in pericarditis are echocardiography and cardiac MRI. and both are very complementary in their diagnosis. And when I say they're complementary, echo is better for assessing hemodynamics, figuring out what are the hemodynamic effects, or what is the effect of the pericardium on the heart. And cardiac MRI is good at looking at the pericardium itself and less good at looking at the hemodynamic effects. So they really work hand in hand there. I've also been asked to speak about what happens in pericarditis and where are our treatment measures. And so what we can see on the far left here is a damaged pericardial cell. And when that pericardial cell is damaged, it releases a molecule called IL-1 alpha. And this IL-1 alpha acts at white blood cells to cause the production of IL-1 beta. This in turn stimulates what's called the inflammasome, which converts inactive IL-1 beta to active IL-1 beta, and this in turn promotes pericardial inflammation through both the action of IL-1 alpha as well as IL-1 beta. This IL-1 beta also stimulates IL-6, which raises your CRP, and COX enzymes, which cause fevers, and all of this is a self-perpetuating cycle. And so we can see that we'll be talking about a number of therapies in the next little while, and we can see how these may fit into this inflammatory process that's going on by targeting different molecules in this inflammatory process. And I'm going to hand over to my colleague, Dr. Alan Klein, to give the next part of the presentation here.
Okay, thank you, Alan. That was excellent presentation. Let me share my screen. So I'm going to be talking about the ACC concise clinical guidance document on pericarditis. As you can see on this slide, these are the three pillars of how you diagnose and manage pericarditis. So on your left, you have an MRI, as Dr. Lewis mentioned. This shows active inflammation. You have the biologic, rilonacept in the middle. And if that doesn't work, you always can have pericardiectomy. As we know, as an intro, the Rhapsody trial sort of put this on the map. Back in 2021, Rhapsody published IL-1 trap, rilonacept, and recurrent pericarditis. And then more recently in JAHA in 2024, this article showed that you have to be on long-term biologics because of the high recurrence rate when you stop the biologic. In 2024, last year, the group, a lot of them on the call, were involved with the International Position Statement on New Concepts and Advances in Multimodality Cardiac Imaging for Pericardial Disease. And these were over 22 experts that came up with position statements about pericardial diseases. And this slide shows basically how the importance of multimodality imaging, whether it's acute and recurrent pericarditis, pericardial effusion, constrictive pericarditis when the lining is thickened, or even pericardial masses. Based on that, we moved on to the more recent 2025 concise clinical guidance document. This is the first ever from ACC talking about an expert consensus on the diagnosis and management of pericarditis. And a lot of my colleagues were on this document as well. So this is basically an abbreviated, concise document that looks at algorithms and tables to allow the clinician to manage these type patients. In this document, I'd like to highlight a few things. Number one, there's a new definition. To define pericarditis, you need the classic pleuritic chest pain, that sharp pain when you take a breath, or other suggestive features, plus two more things. If you have two more things, including a rub, EKG changes, elevated CRP, and increasing pericardial effusion or active inflammation, then it's pretty definite in terms of diagnosis. If you have the classic pain, only one of these things, then it's possible. And if you just have the pain with nothing else, it's going to be unlikely. This is very important because a lot of the patients that we're seeing now may not have all these things. So we're not sure whether this is active pericarditis. Actually, a third of the patients are like that these days. We emphasize in this document multimodality imaging, echo, looking at effusion and the constrictive physiology. The MRI is very, very crucial. It's an imaging biomarker. This will basically grade the thickness, the inflammation, the fluid, and also the constriction. And CT is very important, especially looking at calcification or pre-op planning. As you hear from myself and Dr. Mazzio, the first line therapies have not changed: colchicine, NSAIDs, or aspirin, with exercise restriction accordingly. And then there's a little divergence, as you'll hear. The American guidelines have gone right to the biologic based on recent data, whether rilonacept or anakinra. So bypassing steroids because of all the steroid side effects, especially when there's an inflammatory phenotype. Steroids are still useful, perhaps for the non-inflammatory phenotype for autoimmune diseases. And if you give that, it's low to medium doses with a slow wean. And we shouldn't forget about radical pericardiectomy. Some of the big centers, including Mayo Clinic and Cleveland Clinic, we do emphasize with expert hands, big volume, radical pericardiectomy does help for medical refractory pericarditis. We want to treat the underlying the etiology. And also, I want to bring up the concept of PDCs, pericardial disease centers of excellence, especially for complicated cases. At this point, now I'm going to turn over to my colleague, Dr. Mazzio, to talk about the European guidelines.
Thank you very much for this invitation. I've been one of the two chairpersons coordinating the European Task Force of Experts, and also Professor Alan Klein was included in our task force as an expert from the US. These are the first European guidelines that combine together myocarditis and pericarditis. It was the effort of an international task force, including also one expert from the US. And probably the reason why these guidelines got a high priority to be published in 2025, it was related to the COVID pandemic. The COVID pandemic clearly has shown us the frequency and importance of myocarditis and pericarditis and how they can occur in the same patient. And since this condition affects young people and have also a very important impact on the quality of life in recurrent cases, I think we really wanted to have guidelines for the physician published together with guidelines for patients. So in the European guideline, we'll find a document in English reporting what patients need to know. And these are the 10 key points that are published. And one of the main concepts, the new concept, is the introduction of a new acronym for the cardiology community, but also for patients, IMPS, that stands for inflammatory myopericardial syndrome, a terminology similar to acute coronary syndrome. We want to emphasize the spectrum of disease that goes from simple pericarditis to simple myocarditis through combined forms, including myopericarditis when pericarditis is prevalent, and perimyocarditis when myocarditis is more important. The idea is that if you have a patient with myopericarditis, the treatment should be the same of a patient with pericarditis, and if you have a patient with perimyocarditis, the treatment should be the same of a patient with myocarditis. The reason why these two conditions are together is that they have common etiologies, either infectious or not infectious, and they have anatomical contiguity because the pericardium is on the myocardium. So if you have a very severe form of myocarditis or pericarditis, you can have the secondary involvement of the other anatomical structure. The common practice is to consider myocarditis and pericarditis if they were on different planets, but they are together on the same planets. They are together on the Earth, and often they are in the same patient. And so our idea of the European guideline is that you should consider pericarditis, myocarditis, and cardiomyopathy not as completely separate topics, but some condition that can have similar presentation, and you should be aware of this just to give the patient the best treatment. We recognize the spectrum of clinical presentation. We recognize also that in majority of cases, the presentation is a presentation with chest pain. In Farlight, 70% of cases usually non-complicated. We recognize also the presence of arrhythmic presentation and inferior presentation, and we provide a specific algorithm guided by the clinical presentation. So we have an algorithm of a patient with chest pain. We introduce that if the patient has a low probability of coronary artery disease, the first thing that we have to exclude in a patient with chest pain, we suggest to evaluate the possible presence of red flags for an IMPS that has essentially elements in the history, signs and symptoms from physical examination, electrocardiographic findings, or imaging findings that can suggest the presence of a myocarditis or a pericarditis. We also revised the diagnostic criteria for both myocarditis and pericarditis, and these are consistent with the American College of Cardiology position paper, the paper that Professor Klein presented to you. So for pericarditis, we need a clinical presentation. The main difference of the European guidelines is that we recognize that pericarditis in the elderly can present with dyspnea, so not only chest pain, and we need at more than one objective features to have a definite diagnosis of pericarditis. The other point is that, as pointed out by Professor Klein, we updated the therapies for acute and recurrent pericarditis. We have a pharmaconomic approach. In Europe, not all European countries can have access to anti-interleukin agents. We have to recognize it. We want to take care of the patient in every country. So, of course, the first level treatment for all patients is exercise restriction as a first level of treatment, together with the non-steroidal anti-inflammatory drugs and colchicine. If they fail, the second level is a low to moderate dose of corticosteroids combined with colchicine. And as we may, in different conditions, hypertension, dyslipidemia, heart failure, acute and chronic coronary syndrome, we use often a combination therapy. If you use low doses of a corticosteroids together with a non-steroidal anti-inflammatory drug, together with colchicine, you have better efficacy and less side effects. Only if this treatment, even the triple medical therapy, fails, in the European guidelines, we recommend to consider anti-interleukin-1 agents. What we say, and this is new, is that corticosteroids are not recommended as the first option for patients with pericarditis therapy without a specific indication. That means that you have a specific indication. If you have specific indication, corticosteroids should be considered. For instance, pregnancy. For instance, if you have oral anticoagulants on board, a systemic inflammatory disease or maintenance of steroids, a post-pericardiotomy syndrome, a post-vaccination disease. So we recognize that generally corticosteroids have problem because in clinical practice, they are badly used, higher doses, fast tapering. If you use them properly, probably in the majority of cases, you will be able to take the control of the disease. Last point, we recognize also in Europe the presence of center of excellence, hub centers. So in the complicated cases, consider the presence of different experts and also the referral to an hub center. Let me conclude with a joke. With these guidelines, pericarditis and myocarditis are now married. So please do not separate them anymore to improve the management of our patient. Thank you very much for your attention.
Thank you, Dr. Amatio. So at this time, we're going to start the question and answer portion of the event, and I'm going to hand it to Andy for our first set of questions.
Thank you, Rachel. Our first questions are about the diagnosis and causes of pericarditis. Dr. Klein, what is the role of MRI in diagnosis and treatment? Are there medical guidelines that most doctors in the US follow to diagnose and treat pericarditis? And how are they disseminated?
Andy, thanks. A very good question. So MRI is actually extremely important in this field. It's sort of a imaging biomarker. You can obviously you have to assess the patient, a clinical assessment, but MRI, when it lights up when you give the gadolinium dye, and or if you have edema swelling, can really pinpoint that this is a very active pericarditis. And we have what you call imaging guided therapy based on that MRI. Now we realize that not every hospital in the country or in Europe or different countries have access. So it's nice to have it. It's not essential, and it's now one of the criteria for pericarditis. Now, about guidelines, as we just heard from Dr. Mazzio and Dr. Lewis and myself, there are guidelines, there are consensus statements, expert opinion out there. As I mentioned, we have the 2024 JACC imaging consensus paper, the 2025 ACC paper, and now the 2025 ESE paper. So it's out there. Some are, quite long, but you can look at a specific table for management.
Thank you, Dr. Klein. Dr. Mazzio, do we know what causes acute and recurrent pericarditis and what causes flare-ups? And how frequent is post-cardiac injury a cause of pericarditis?
Okay, thank you very much for this question. We know that there are infectious and non-infectious causes. We know that there are systemic conditions such as a systemic inflammatory disease that can be responsible for pericarditis and also recurrences. We know also that there are genetic conditions such as autoinflammatory disease, not so common in clinical practice, but possible cause of recurrences. And also we have evidence that in contemporary cardiology practice, due to the increasing age of the population, the increasing number of interventions, we have a lot of post-cardiac injury cases related to pacemaker implantation, ablation of arrhythmias, surgery, cardiac surgery, but also coronary intervention. So there is an increasing number of cases. In practice also, a very common cause of recurrences is represented by a late diagnosis, a late treatment, and also a non-guideline directed medical treatment, because many patients are not treated according to guidelines. So guidelines and position paper are very important because they are like the standard of treatment, the best dosing and tapering regimen.
Thank you, Dr. Mazzio. Next question for Dr. Luis. Have you seen a rise in the number of recurrent pericarditis cases since the COVID-19 pandemic? If so, could this be from the COVID-19 vaccines? And does pericarditis from COVID or a COVID vaccine differ from other forms of pericarditis? Is it recommended to continue to get COVID boosters if someone got pericarditis from a COVID vaccine?
That's a great question, Andy. So I think, to start with, when we look at the overall number of recurrent pericarditis cases, we have not seen an increase since the COVID-19 pandemic. I think, we are, in some ways, as pericardial providers, we are thankful that COVID-19 has raised the awareness of pericarditis as a disease process, but overall it has not changed the number of cases of recurrent pericarditis that we see. I think it's really important when we talk about vaccination to remember that COVID causes illness that's for pericarditis that's 10 times worse than a COVID vaccine. And so it's important to keep that perspective. Although there's a lot of press of COVID vaccine, COVID actually causes far worse pericarditis than COVID vaccine does. In terms of COVID boosters, it's really a balance of risk versus benefit. When we look at someone who's severely immunosuppressed or is receiving cancer therapy and things like that, there the benefit may outweigh the risk. I think in the majority of my patients, I generally tell them to be careful, use other precautions such as masking, avoiding people that are sick or known to have COVID. But we do know that that COVID booster does carry a potential risk of a flare of pericarditis. And so I don't routinely recommend COVID boosters in someone that's had pericarditis due to a COVID vaccine previously.
Thank you, Dr. Lewis. And the following questions are about treatment. And I'm going to go straight to Dr. Mazzio for the considering time. So there is a lot of talk, Dr. Mazzio, in the patient forums about biologic treatment, but these aren't easily accessible in many countries outside the US. If the usual first-line treatments of NSAIDs and colchicine aren't working, what do you suggest for patients who can't access biologics?
In my country, in Italy, we have access to biological agent, but in many European countries, the clinician don't have access to these drugs. This is the reason why in the European guidelines, as you have seen, corticosteroids are still considered the second option, the second step in a patient with the recurrent pericarditis. And we recommend also the combination therapy of low, moderate doses of corticosteroid together with colchicine and non-steroidal anti-inflammatory drugs. And only if this treatment fails, we recommend to go to biological agent. Even in Italy, we are allowed to use anakinra because in Italy we don't have access to rilonacept, only in case of failure of triple therapy, including corticosteroids. So I think this is an option that we should be considered in countries where anti-interleukin-1 agents are not available.
Thank you, Dr. Mazzio. Dr. Lewis, we had multiple questions about the recurrence of pericarditis after tapering off Arcalyst. Can you speak to the proper protocol for how someone should taper off or should come off of Arcalyst for tapering off? And the best thing to do if someone has a recurrence after tapering? And what is the success rate for discontinuing using Arcalyst, please?
That's a great question there, Rachel. And I think the Arcalyst lasts in the system much longer than anakinra used to. We've tried multiple different protocols for tapering people off Arcalyst, and this includes increasing the spacing out of the Arcalyst. We've also tried to dose reduce the Arcalyst, but unfortunately, there hasn't been an ideal way of solving this. And no matter how we've tapered it off, the recurrence risk does not seem to be different. The unfortunate thing is that the risk of discontinuing Arcalyst, the recurrence rate is said to be around 75% when we look at the results from the Rhapsody study. There are 8 people discontinued, of whom 6 recurred at that time. And so, unfortunately, we do need new strategies, and there is some research in the pipework that may help us in terms of this dilemma.
Thank you, Dr. Lewis. My next question is for Dr. Imazio. Are there ways to avoid acute pericarditis turning into recurrent pericarditis? For example, a few people asked if the use of steroids can contribute to recurrence. Can you speak to that and other factors?
Okay, thank you for this question. So the early use of corticosteroid without a specific indication is one of the reasons, and this is the reason why in the European guidelines they have a class fee. So they are contraindicated without a specific indication. The other problem is that often in clinical practice, especially in the past, less in the present, they were used at high doses with a very fast tapering. So they have an impressive effect on the diffusion, on the symptoms, but if the tapering is very fast, then the disease can come back. Another point is that sometimes the treatment is not given properly. So this is the reason why in the guidelines and position paper, we also are proposing dosing, because, for instance, if you have ibuprofen, you should do this 3 times a day to a full anti-inflammatory dose. And sometimes the dosing is not appropriate. So I think that probably with more guideline-directed medical treatment, we can prevent more prolonged course of the disease and more recurrences.
Thank you. Dr. Lewinter, if one biologic doesn't work for a patient, is it possible that another would? For example, anakinra versus Arcalyst?
Right. Well, those indeed are the 2 biologics that are available. And biologics are extremely efficacious. The vast majority of patients, if the diagnosis is correct, that is idiopathic or perhaps post-injury recurrent pericarditis, the drugs will work, and quite effectively. So the first thing to ask, if a biologic doesn't work, do you have the correct diagnosis? Is this some other problem masquerading as pericarditis? And for example, this might be a place where you would consider MRI, as Dr. Klein mentioned, to be a little more certain about the diagnosis. The question was, if one doesn't work, would another work? And I think the answer is it's very unlikely. Both of the available biologics work through inhibition of IL-1, as Dr. Luis mentioned, and therefore it's not anticipated that one would work if the other doesn't. I think it's conceivable, though, although they interfere with IL-1, the mechanisms are slightly different. One is a receptor blocker, the other is what's called a trap. In other words, it kind of sops up all the floating, the IL-1 in the blood. So it's, in theory, it's conceivable that there could be some difference in their efficacy based on the slightly different mechanism, but ultimately it all winds up being IL-1. So I think, again, the short answer is very unlikely if one doesn't work, that another would work.
Thank you, Dr. Lewinter. Okay, Dr. Klein. Does treatment protocol change if you have an autoimmune disorder and pericarditis?
Andy, very good question. So the question is about autoimmune versus autoinflammatory. So when we see a patient, we try to put them in two buckets. Autoinflammatory would be something like from a virus or after open heart surgery or trauma, and autoimmune would be something like lupus or rheumatoid arthritis. So they're almost two different things. So the autoimmune would be often seen by a rheumatologist, where they have their own set of drugs, such as Plaquenil or Cellcept, methotrexate, Imuran, and the cardiologist would have the the NSAID, colchicine, the steroids, and the IL-1 blockers. Now, normally for a lupus patient, I use that as an example, you wouldn't necessarily put them on an IL-1 blocker, but there are increasing series that the usual medicines for the lupus patient with pericarditis are not holding. And then you have to have a good discussion with the patient and the rheumatologist whether you would want to try an IL-1 blocker. And there's been some success. It wouldn't be the first line. There would be have to be a good discussion, but the IL-1 blockers have been used, for example, in lupus in some patients with good success. But the problem is that you can't have too many drugs, otherwise you're very immunosuppressed. So this is an evolving field of interest, but that's a simple way of looking at it. Look at it, two buckets and see which one. Now there's overlap. A lot of autoinflammatory patients have a genetic background. They have a mother with lupus or a sister with rheumatoid. So definitely there's more that we have to learn and the genetic basis for this.
Thank you, Dr. Klein. Dr. Mazio, people are interested in knowing when it's safe to taper off medications used to treat pericarditis and when they can start to increase physical activity. Are there guidelines for patients to follow?
Thank you very much for this question. In the European guidelines is clearly reported that our approach to the physical restriction should be individualized, because one size does not fit all. And so we have really very mild form of pericarditis or myocarditis that can reach a clinical remission in 1 month. So in the guideline, we say stop physical activity, restriction of physical activity during the acute phase of the disease for at least 1 month. Then if the patient has a clinical remission, and we provide criteria for clinical remission in the guidelines, all of the patient to go back to physical activity. This is for myocarditis, pericarditis, athletes, non-athletes. So an individualized approach to treatment. That is very important for the patient. Often these patients are young. They want to go back to work or to their physical activity. To provide the arbitrary restriction of physical activity as in the past 3 to 6 months is not appropriate.
Thank you, Dr. Mazio. Next question is for Dr. Lewis. Are there health and mortality implications to having a pericardiectomy? When should someone consider having a pericardiectomy?
Thanks, Andy. So I think, given that we're talking about recurrent pericarditis and inflammatory pericarditis here, it's probably worthwhile to focus on that and realize that that's different to those people with constrictive pericarditis. The outcomes from surgical pericardectomy in patients with recurrent pericarditis is very, very good. In fact, we had published a series of patients that had pericardectomy for recurrent pericarditis, and there was no one that died in that series from their pericardectomy. There were 2 people that had serious adverse events. And when I say serious adverse events, one of them had bleeding that needed to go back to the operating room, and one of them had a stroke. And so the outcomes from that operation are very good. When we look at the overall outcomes in terms of freedom from pericarditis, they had a 90% or so long-term freedom from pericarditis recurrence, so really extremely good. The comparison group at that time were not people on IL-1 blockers, but people on usual medical therapy who had a high rate of recurrence in comparison. So pericardectomy is definitely something that's effective in patients with recurrent pericarditis to deal with their symptoms of chest pain. In terms of implications of removing the pericardium, we don't see much in terms of long-term sequelae from removing the pericardium. I think when it comes to considering who to go to have a pericardectomy done, I think that's really a very, very important question. Our recommendation is that pericardectomy is generally done at a center that has a lot of experience in dealing with patients with recurrent pericarditis, because what we need is a surgeon that has experience in doing this and has done a lot of this. And so really we would recommend referral to a pericardial center of excellence. You really want to ask the person, how many of these pericardectomies have you done? And particularly, how many pericardectomies have you done for recurrent pericarditis? You also want to know how much of the pericardium that they're going to remove. And really what we're looking for in a patient with recurrent pericarditis is a surgeon that's going to remove the pericardium in its entirety. And yes, there is a little bit of pericardium that runs along the nerves that supply your breathing muscles. And so that little bit gets left behind. But by and large, that pericardium should be removed in totality. And sometimes the word complete and radical pericardectomy are used. They don't necessarily mean that all the pericardium is taken out, as the name suggests, but it's really, really important to ask the surgeon, how much are you taking out and how much will be left behind?
Thank you. My next question is for Dr. Lewinter. Can pericarditis symptoms be managed more effectively by supplementing medications with diet, supplements, exercise, and alternative medicine?
Well, again, the short answer is there's no evidence that any of these things will have a meaningful impact with recurrent pericarditis. It's important to separate out exercise, though, because it's in most situations with cardiovascular disease, exercise is good. And for a variety of reasons, it conditions you, it has anti-inflammatory effects, but has been discussed. Exercise is a no-no in most patients with pericarditis, so that's a little different. The other things on that list cover many bases, and so it's obviously important to talk about what we really mean with all these things. But there's been very little research. There is one ongoing trial of a cannabinoid in recurrent pericarditis, which looks to be a well-constructed trial and might give us some good answers. But other than that, there is no evidence at all for any of these things.
Thank you, Dr. Lewinter. These questions refer to living with pericarditis. Dr. Alreyes, do medications contribute to the healing process, or are they just managing symptoms? Can untreated pericarditis cause lasting damage? And are there any long-term health considerations to be aware of after a flare-up of pericarditis?
That's a very good question. Thank you so much. Definitely, these medication have a dual, some of medication have dual effect, like healing and managing. For example, when somebody have a flare-up or the first episode of pericarditis, they have the NSAIDs, which is managing the pain and fever and reducing the inflammation. But for example, colchicine and biological agents are more anti-inflammatory, and also they are modulating the immune system to be less kind of aggressive in managing this infection or inflammation. So if untreated, there is definitely consequences. We already covered most of them earlier, is about causing pericardial effusion, constrictive pericarditis, cardiac tamponade, and effusion, which is sometimes can be catastrophic and requiring pericardectomy, as Dr. Lewis already alluded to. So what we need to do is to treat the first episode definitely as aggressive as possible with the appropriate medication and avoid the NSAIDs and avoid the steroids, because 30% of patients who develop first episode of pericarditis have a risk of recurrent pericarditis. 30%, 1 out of 3 people almost have that. So therefore, this medication has to be started early and with the highest dose. And if these patients have recurrent episodes, be treated with biological agents, as already covered by the other panelists.
Thank you, Dr. Alvarez. Dr. Klein, this question's for you. So if someone has a flare-up and they go to the emergency room, what should be the follow-up for them after going to the emergency room?
Okay, Rachel, very good question. Let me just back up. So once again, there's a big educational gap in, let's say, in the emergency room about, let's say, some of the newer guidelines that we just talked about. So that's the first thing. So assuming that they do have active pericarditis, there should be a definite follow-up, whether with the heart team, whether the cardiologist or the, say, the APP in terms of a follow-up. Like at Cleveland Clinic, the emergency patient would have a follow-up, and either to their own cardiologist or they get referred to the Pericarditis Disease Center. And there you have to help manage their medicines if they're put on NSAIDs and colchicine. Exercise restriction, there has to be a good discussion, and there's a gradual weaning of the medicine. Somebody has to manage this. Often patients are searching, many for several weeks to find the right provider. If they go on biologics, there has to be a discussion with the cardiologist or the APP for how long do they have to be on the biologic, how do you wean the other medicines, how often do you get imaging if available and if necessary. So there has to be a lot of good follow-up, and I don't think the follow-up is that great when I talk to a lot of these patients. So crucially, to have the ER physicians learn more about pericarditis, some of the newer algorithms, and definitely have follow-up with the Pericarditis Disease Center or their cardiologist.
Thank you, Dr. Klein. And Dr. Amatio, for patients with recurrent pericarditis, what factors best predict a good long-term outcome? Is being symptom-free for a certain amount of time a good sign? And does recurrent pericarditis ever fully heal in most patients?
Okay, thank you. Very important question for patients. So in my view, what is really important is to have an early diagnosis, an early treatment, and I would say a guideline-directed medical treatment with the exercise restriction during the acute phase of the disease, an early return to work or to play during the active phase of the disease is not recommended. I would also recommend the avoidance of steroids without a specific, but I would add without a specific indication, because sometimes there are specific indication for these drugs. And also the early use of colchicine is very important and sometimes is missed.
Thank you. Dr. Alvarez, I have another question for you. Is there anything that someone with recurrent pericarditis can do or should be aware of when planning a pregnancy?
That's a very important question. Thanks for asking. Definitely, this is a very critical topic, especially in young women. Number one, you have to have the right team approach, which is the pregnancy or heart team approach, where there's obstetrician as well as the cardiologist who is involved in the therapy of this individual before planning the pregnancy. So ideally, the optimal timing should be when the pregnancy should be planned during the phase or when there is disease is completely subsided and symptoms are free and inflammation is completely the lowest, or like indicators such as CRP or MRI showing no inflammation. However, if the patient became pregnant during the phase of pericarditis or developed pericarditis during pregnancy, so there is certain precaution has to be watched for, and certain medication has to be monitored. For example, the NSAID like ibuprofen, the indomethacin are acceptable only in the first and second trimester of pregnancy, but beyond 20 weeks should be avoided and stopped. Colchicine, on the other hand, is continued to be throughout pregnancy is considered safe, although there's little data about the safety, but considered in general safe to continue throughout the pregnancy. In terms of interleukin-1 inhibitors or the immunomodulators, there is concern we should be stopped during pregnancy because there is insufficient safety data about this infusion or medication itself.
Thank you.
Thank you. The next two questions discuss persistent symptoms. Dr. Lewis, how do doctors know when to stop a medication and suggest a clinical trial medication instead? And what pericarditis clinical trials are taking place now?
That's a great question, Andy. And I think, really when to stop a medication and suggest a clinical trial medication instead. Really, when we think about this, we think about a medication that's not working for you. So if you're a patient and you're having pericarditis treatment and you are not getting any better, that's the time when we start to think about alternatives. And part of our alternatives is the clinical trial medications to keep them all in our armamentarium of what we can potentially use. The other potential group of people is people who have intolerable side effects to the medications they're on, and where you're looking for an alternative, again, thinking of clinically available and potentially clinical trial medications all at the same time to get a particular patient the best advantage possible. In terms of clinical trials taking place at the present time, we talked earlier about IL-1 inhibitors and the difficulty that we face in getting people off IL-1 inhibitors due to the high recurrence rate. And there is a company running the Maverick trial, which is using a study drug to see whether we can stop an IL-1 inhibitor after an adequate length of therapy and reduce the risk of recurrence when we stop an IL-1 inhibitor. So that's called the Maverick trial, and that's an exciting trial for those people on an IL-1 inhibitor who want to come off treatment. We have for patients that are having pericarditis at the present time who have not been on an IL-1 inhibitor and who need treatment to be escalated. We have a Ventyx study drug which blocks the NLRP3 inflammasome. That's where the IL-1 alpha was acting to convert IL-1 alpha to IL-1 beta. And so that's another exciting trial as a potential treatment before IL-1 inhibition, because we don't know what the recurrence rate for other medications will be long term. And so that's a potential exciting option. And then there is another IL-1 inhibitor coming onto the market or coming into clinical trial that has a longer duration of action than both rilonacept and anakinra. And so this may be exciting for people that are starting an IL-1 inhibitor who want to take medication less frequently, and also for those people that are stable on an IL-1 inhibitor who also would like to take their medication less frequently. What I would suggest is that you chat with your doctor to find out which of these trials may be a consideration for you and where they're better or worse than current therapy, because everything has its advantages and disadvantages. And as the doctor, it's important for us to pick what is the right option for you, be it a clinically available option or a clinical trial option.
Thank you, Dr. Lewis. My final question is for Dr. Mazzio. Why do some people experience persistent symptoms despite treatment and having normal inflammatory markers and imaging? And why do others not respond well to any of the treatments? What do you recommend for patients and their doctors who do not respond well to any treatments?
Thank you very much. Very important question. So as pointed out by Dr. Lewinter before, what is really important is to be sure of the diagnosis. As this patient really pericarditis, so this is the reason why in the American position papers, in the European guidelines, we pointed out that we should have objective criteria of disease beyond the clinical presentation. This is why in the American position paper and European guidelines, we pointed out that we have cases of definite pericarditis, possible pericarditis, but also unlikely or rejected. So this is very important because imaging and multimodality imaging can assess non-invasively pericardial inflammation. If pericardial inflammation is completely absent, one should question about the diagnosis. But the good news, as Dr. Lewis pointed out, is that we have ongoing trials. There is a really big research in different pathways for new drugs for pericarditis. So this is the good news for the patient, that we are looking for new treatments that probably can help more our patient to achieve a stable remission.
Thank you, Dr. Mazzio. We had a couple extra questions. If there was time, it looks like there's some time. So these final questions are from viewers who want to wanting a deeper understanding. And Dr. Amacio, I'm just going to ask you to hang around here and speak to the IMPS that you mentioned earlier, inflammatory myopericardial syndrome, please.
Yes, as I pointed out at the beginning of my presentation, this is the new concept to increase the awareness of physicians that myocarditis and pericarditis cannot be present in the same patient because common etiologies, anatomical contiguity, and this is very important because the point of view of the European guidelines is that we should have no more separate experts in the treatment of myocardial and pericardial inflammatory condition. This is because the patient goes to the physician without a written diagnosis, but with symptoms. And sometimes the symptoms are complex. It's not simple pericarditis or simple myocarditis. So this is the concept that one clinician should always have the suspicion that in the same patient, myocarditis can be together with pericarditis.
Thank you. And Dr. Lewinter, how is the assessment and care for mental health, the mental health burden of pericarditis incorporated into treatment protocol, or is it incorporated into treatment protocol?
Your comment about it's not being addressed is often more important than being addressed or how you address it. This is extremely important and doesn't get, in my opinion, does not get enough attention. This is it's a very significant thing for patients, often young, previously healthy, to all of a sudden have cardiovascular disease, and all that brings up, and cardiovascular disease, which is very disabling and completely unpredictable, and that is recurrent pericarditis. So firstly, you've got to be very sensitive to this, and at times it may even be, and you need to take it very seriously because it's having a real impact in your patient's life. Occasionally, it may be helpful to enlist the help of social service, a social worker, or even a psychologist who are better trained, certainly, than cardiologists to work through these sorts of things. But there's the mental health burden is probably the best treatment for the mental health burden is effective treatment. If you've got an effective treatment that allows your patient to, with much higher predictability, resume a normal life, that does a great deal. The other thing you can do, I think, is to reassure people with recurrent idiopathic pericarditis is that ultimately it's highly likely this is going to go away without permanent damage. Again, I think that's a very helpful thing to tell people. It's not fun to have to live with it, of course, for several years, but at least there's some light at the end of the tunnel in most cases.
Dr. Winter, thank you. That is encouraging. So we have a final question, and it's for Dr. Klein. How can patients determine if their cardiologist is best suited to treat and manage their pericarditis if they're not able to access a pericarditis specialist? And how does a patient access care at a pericardial disease center?
So I'd say it's a very good question, Rachel. I guess I'm the closer.
Thank you.
The baseball analogy. So the first thing I would do is, if I was a patient, I would do Dr. Google. I would sort of type out pericarditis and cardiologist and see what comes up. And obviously, people who treat pericarditis will hopefully have something on their website. That'll be number one. Number two, you can ask your cardiologist whether how many people he's been treated with pericarditis. Does he know about some of the newer aspects, the biologics, the role of imaging? And if the answer is not very good, then there are pericardial disease centers out there. The Pericarditis Alliance can provide some specialty centers that deal with this. In terms of if you're not happy, you try to find one of these. Now, you could just call the Pericardial Disease Center. Obviously, there should be a number, and then you get referred to, let's say, if they call my office, I'll definitely try to get them into the Pericardial Disease Center. If they call the Mayo Clinic, Dr. Lewis will try to accommodate that. So I think there's a lot of good internet resources out there, especially the Pericarditis Alliance. I'll put a plug for this. There's a social media page, Facebook as well. But I think there's more knowledge out there. There's new guidelines, there's new consensus statements. So I think this field was an old field, sort of neglected, and now it's making a new renaissance. And I think we want to help these patients. And I think I want to thank the Alliance, Rachel, and the team for Donut for making this happen. And it's nice to see a big international presence with us. So thank you very much.
Thanks, Dr. Klein. Thank you for everyone for answering the questions, everybody. And yes, we have 4 centers of excellence on our website. I believe that there are links to them. And then the link should probably send you to in the direction of getting an appointment. So thank you for joining us. Thank you to the doctors for helping us better understand pericarditis. We hope that this has been informative and engaging. If you want more resources, visit our website or our Inspire page or join our support group. We're also on Instagram and Facebook, X, and LinkedIn. And until next time, thank you very much.